Hello, everyone, and thank you for joining us for Arthritis Talks, Arthritis Medications. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. First off, we've come together for this event from many different places, but I would first like to acknowledge the land on which I am located on and on which our Toronto office stands, and that is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I am very grateful to have the opportunity to live with my family and work on this land. There are over 6 million people in Canada living with arthritis. And though medication isn't the only option in terms of arthritis treatment, there are often very effective ways to help relieve arthritis pain, reduce inflammation, and slow joint damage. Yet the world of arthritis medications can be confusing to understand, and today we have rheumatologist Dr. Janet Pope here with us to answer many of your questions we receive about arthritis and medications. Now, before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have any technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen, and we'll try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and our chat moderator. If you find that distracting, you can close out of the chat completely. Just click on the red X icon to close out of the window. Also, we are pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, so you'll see that running along the bottom of the page. Now, we have received literally hundreds of questions in advance of tonight's webinar, more than we have had in quite some time, and many of those have followed similar themes, so we will get to those first, and then we'll go into a live Q&A at the end of the session. Before we get started, I want to thank our event partners, Nordic Pharma, our exclusive event presenting partner. In addition to the support of Nordic Pharma, we are also grateful to Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talks series. Now, let's get started, and first, a very warm welcome to today's expert, Dr. Janet Pope, who is joining us from Ontario. Dr. Pope, welcome, and let's start with a really important question that we often receive. How do medications used to treat inflammatory types of arthritis differ from those for osteoarthritis? And can you use them for either? Do they work for both? I'll hand it over to you.
Okay, wonderful question. And I'd love to also have a warm welcome to everyone because such a wonderful turnout and people can also watch it later. So this is great. So when we look at inflammatory arthritis, that's things like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis or SPA, spondyloarthropathy. Those are the inflammatory arthritis type conditions. There's more than that, but they're the more common ones. And for osteoarthritis, that's degenerative arthritis where the problem originates in the cartilage, the lining of your joint, or the bone right below it. Whereas in the inflammatory arthritis, the problem starts often in the lining of the joint, the synovial lining, or sometimes where tendons are inserting around bones. And the reason that the treatments are different are because some treatments would be shared, where we'll get into this more later, but non-steroidal anti-inflammatory drugs are what you commonly know of as NSAIDs, so the ibuprofen, Aleve, Advil, Motrin, etc. We'll talk about those later, but they could help pain from any of these conditions, and they can help inflammation a bit. They help inflammation and pain. But when we look at what we call disease-modifying drugs, unfortunately, thus far in osteoarthritis, most of the disease-modifying drugs have actually failed in trials, whereas in the inflammatory arthritis, disease-modifying drugs, which we'll discuss further, have positive data where they're hitting the cells that are targeting inflammation around the joint lining or the tendon insertion. We also think of prednisone or cortisone that we'll talk about later, and that is often used in inflammatory arthritis for a flare. Whereas in osteoarthritis, we wouldn't want to use oral prednisone for osteoarthritis. Even though it can help pain and swelling, it's not the most appropriate treatment. So we could inject joints in any of these conditions, whether it's osteoarthritis or inflammatory arthritis, with steroid injections, or what you think of as cortisone shots. And we will talk about that too. And you can inject the joints and help pain and inflammation. So there's a bit of overlap, but there's wide underlap, because in inflammatory arthritis, we have way more drugs within those disease modifying category that are helpful. There will be hope for osteoarthritis later, which we might talk about at the end.
Okay, so that was a really helpful answer, Dr. Pope, and I think many of our viewers will appreciate it. Could you discuss a little bit about what medications are available specifically to treat inflammatory forms of arthritis?
Sure. And as I'm doing that, here are my disclosures as well. So I am lucky enough to have a lot of pharmaceutical funding that probably in many ways makes me a better doctor. I learn from learning and teaching. Medications available for inflammatory arthritis. So we think of it in categories. So helping the pain and inflammation, quick acting would be the non-steroidal anti-inflammatory drugs, or the NSAIDs, over the counter or prescription. The glucocorticoids, or what we think of as prednisone, cortisone, what we call the steroids. The disease-modifying anti-rheumatic drugs, or we call them DMARDs, disease-modifying anti-rheumatic drugs. And of that, there's subcategories. The conventional synthetic ones we'll talk about, that's our, nothing wrong with them. They're excellent. They're anchor drugs often, but they're the older drugs. The biologicals, which are newer drugs, and the targeted synthetic DMARDs, which are relatively new. So the NSAIDs, everyone knows someone who's taken an NSAID. There's over-the-counter ibuprofen, also known as Aleve, or Motrin. There's over-the-counter drugs such as anaprox or naproxen kind of drugs that you've heard of. Then there's also, in addition, higher doses by prescription of those products, as well as celecoxib, also known as Celebrex, meloxicam, also called Mobicox, naproxen or naproxen, diclofenac, which is Voltaren, or Arthritec. It also comes in gel, Voltaren gel or diclofenac gel, or in a solution. There's also other ones that I haven't written here, less used, tarprophenic acid, namibutone, indomethacin, etc. So what do? They're fast acting. They help pain and swelling, and they also help a lot of other pain. So people that have problems with headaches or shoulder tendonitis or plantar fasciitis or mechanical back pain, they can help them. The problem is, in general, they don't change the natural history of the disease to try to prevent damage over time. So they're not really preventing damage. We want to ramp down the inflammation. That's almost always true, except for probably, very high doses can help prevent some joint damage and ankylosing spondylitis, but that's a unique situation. And rheumatoid or psoriatic arthritis or osteoarthritis, in general, they don't prevent damage. Then there's a broad category, the steroids. So everyone's heard of prednisone. That's also called corticosteroids or glucocorticoids. Oral would be prednisone or prednisolone, rarely dexamethasone. Intravenous, there's solumedrol or solucortef. Intramuscular, it's depomedrol or triamcinolone hexacetonide, triamcinolone acetonide, celestone. There's many of those products. Intramuscular, mostly depomedrol, and the other products I just mentioned are often also given intra-articular, which is in the joints or around a tendon sheath. So soft tissue or joint injections. And these are the drugs that we want to, in general, use very sparingly. If someone has polymyalgia rheumatica, PMR, that would be the prednisone, long-term, low dose, eventually stopping it would be the drug of first choice. But for many of our inflammatory arthritis conditions, we would only use it as bridging or short-term. And something like vasculitis, it might be very high dose, or lupus, very high dose, and then going down over time. And in osteoarthritis, we would try to always avoid oral prednisone, but maybe people would get injections, say, in their back, epidural steroids or facet injections, or injections in a knee or in the small joints of the fingers, etc. When we look at the next group, the conventional synthetic DMARDs, so the old-fashioned, which are still in use, very effective, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. Other ones we used to use were gold injections, and there's a few others not very commonly used, like for rheumatoid or psoriatic, drugs like azathioprine. There's other ones, though, that we might use in the other category for things like systemic lupus erythematosus, which I'll call lupus. So that's Imuran is the trade name, azathioprine or AZA, we sometimes call it. Mycophenolate mofetil or Myfortic, also called MMF. Those two are common in lupus, systemic lupus erythematosus. Cyclophosphamide for vasculitis, for severe lupus. Cyclosporin sometimes for inflammatory eye diseases, but also cyclosporin or tacrolimus. These are calcineurin inhibitors. We might use them in inflammatory myositis, as well as in lupus, kidney lupus, lupus nephritis, and not so much, say, in psoriatic arthritis or rheumatoid or ankylosing spondylitis. So I think people listening are getting a sense that there's classes of drugs, but there's nuances where certain drugs are used for one indication, but maybe not so well tolerated or not so helpful in another disease. Biologics, everybody's heard in the newspaper and news for now, probably since 1999, our first ones, and then it came out, 2000, government approved. So the TNF inhibitors, or we call them TNFs. So the anti-TNFs or TNF inhibitors are, I just put them in an order of types and then in order that they came out. So infliximab and adalimumab are monoclonal antibodies. Etanercept is a receptor antagonist. All of them will downregulate TNF inhibitors. Golimumab and sertolizumab pegol don't yet have biosimilars. The stars are for the ones that have biosimilars. IL-6 inhibitors, we have two of them, tocilizumab and seralulimab. There's other biologics that we use routinely in some patients with some diseases, abatacept, rituximab. Abatacept is currently only approved in rheumatoid arthritis, and by the way, juvenile arthritis as well, and some of these are also in juvenile arthritis. Rituximab's in vasculitis, rheumatoid arthritis, some other conditions sometimes. Belimumab and anifrolumab are newer kids on the block in lupus that's highly active. The IL-12/23 ustekinumab, which now is a biosimilar as well, and gulsulcamab and risankizumab. Those are used in seronegative arthritis. That means psoriatic arthritis. Not so great in ankylosing spondylitis, some of that class, but they're also used in inflammatory bowel disease. Again, some overlap, as are the TNF inhibitors. Then there's IL-17 inhibitors. They're used in psoriatic arthritis. They are used also in ankylosing spondylitis, but they don't work in Crohn's disease or inflammatory bowel disease. So again, nuances of sometimes the colleagues in other specialties use them and sometimes they don't, depending. And IL-12/23s, IL-23s, and IL-17s are all quite excellent in psoriasis. And TNF inhibitors are also used in psoriasis. And the IL-17 inhibitors or secukinumab, also called Cosentyx, ixekizumab, also called Taltz, bimekizumab, which has come out more recently in psoriatic arthritis, but has been around for several months now in psoriasis. And there's brodalumab or brodalumab, which is only in psoriasis. That's an IL-17 inhibitor. And by the way, there's more to come. So there's a whole kind of potpourri, and there's ones in vasculitis that I haven't mentioned that are also used in severe asthma. There's some used in atopic dermatitis that we don't use in our patients with inflammatory arthritis. We also have the targeted synthetic DMARDs. So again, these are small molecules, the way the regular DMARDs are conventional synthetic. So JAK inhibitors, the first one was approved in 2012, tofacitinib, also called Xeljanz. There's baricitinib, Olumiant, and upadacitinib, which is also called Rinvoq. There's other JAK inhibitors used actually to treat some kinds of cancer. There's JAK inhibitors that also can treat atopic dermatitis. And now, just recently, baricitinib, like within the last several weeks, was approved in Canada for alopecia areata, so autoimmune hair loss that's often in a circle and can be quite devastating for people, because nobody wants their hair to fall out for no particular reason. There's TYK2 inhibitor, deucravacitinib, which is called SOTYK2 is its name, and there's more to come. And there's PDE4 inhibitors, apremilast, and another one that's coming. And the PDE4 inhibitors are psoriatic arthritis use or psoriasis. SOTYK2 is being trialed in lupus, as is upadacitinib, and so TYK2 or deucravacitinib is approved in psoriatic arthritis and has positive data in ankylosing spondylitis, and of course in psoriasis. So you can see the whole spectrum. Again, some work in one disease, some work in many. Tofacitinib is approved in ulcerative colitis. Upadacitinib is approved in ulcerative colitis and Crohn's disease. Baricitinib, unfortunately, didn't meet their endpoints in lupus, but tofacitinib isn't looking in lupus. Upadacitinib is in phase 3 in lupus trials. So lots going on. So it's a little bit of a category that's kind of up and coming, with new indications probably happening every many months.
Okay, so you just covered a ton of information, Dr. Pope. Thank you. I think that's a great broad overview. Just so you know, we've had lots of questions come in about some specifics about some of the drugs and certain conditions. So just rest assured to the audience that we're going to get to those specific questions near the end. But with that, let's move on for a second. So now that we have a much better sense of what's available for inflammatory forms of arthritis, what about osteoarthritis?
Right. So osteoarthritis is really common, and osteoarthritis is probably many different diseases. So knee and hip osteoarthritis are different from each other, and they're different in how they look on X-ray from bad hand erosive osteoarthritis, which is the middle knuckles, the end knuckles, sometimes the base of the thumb. And not everyone has to have all those knuckles involved. But erosive osteoarthritis actually has a little bit of positive data with methotrexate, but that would not be routinely used. It wouldn't be in usual guidelines because there isn't always enough benefit for buck potential side effects, because buck isn't cost. Methotrexate is pretty, relatively speaking, inexpensive. So for most osteoarthritis, we want to think of non-drug treatment, weight loss, orthotics, strengthening, physiotherapy, aids. Occupational therapy can help with orthotics and helping with aids to help people, braces, resting or working wrist splints, etc. We also have the NSAIDs that we talk about. We have the topical pain medication. So, and then we have acetaminophen, that's Tylenol. And if your kidneys and your liver work fine, and if you're below a certain age, acetaminophen can be up to 3,000 milligrams a day, but it's down adjusted in people who are a bit older, people with kidney or liver issues, which might be up to 2,000 milligrams a day. So that's 2,000 milligrams is 6 of your regular strength Tylenols. So you can use quite a few, and it's 10 of regular strength Tylenol as for instance, of 325 milligrams of maximum dose for the populations not at that higher risk. The NSAIDs are the ones that I talked about. They can be topical, they can be oral, they can be as needed, and in some people they're regularly used. We have duloxetine. So duloxetine is quite interesting. It is approved for depression. It's an antidepressant. It's also approved for widespread pain in fibromyalgia, and it's approved for pain from osteoarthritis. So it has a very broad access in how it helps pain. Now, sometimes people have depression and they're not on duloxetine, they're on a different antidepressant, we'll say sertraline and other ones. And some of those drugs also centrally act to help depression, but they can also help pain. And then opioids are usually used only sparingly, sort of while someone's on a severe night pain or rest pain, or while they're on the waiting list for joint replacements. So we don't have DMODs, disease-modifying osteoarthritis rheumatic drugs yet, but some looked promising, and there's actually one approved, a nerve growth factor inhibitor, so it gave neuropathy. It seemed to help osteoarthritis, but in some people it made the osteoarthritis far worse. But it's approved in cats, and it's a biological, and it's an injection, and it helps my friends who are rheumatologists. Have one of my friends has their cat on it, and they said it works. The cat was walking far better, but not for human use. But there are other drugs on the horizon that are all sorts of signaling pathways to try to stop the bone contusion or damage that's signaling to break down cartilage that then is causing pain and suffering, but also causing bone-on-bone degeneration. There's also injections, some common ones, and I'll tell you some controversial ones. So the common ones are usually steroid injections. The glucocorticoids are what we call depomedrol or triamcinolone. There's also injections of viscoelastic substances. There's many of them. So that's the hyaluronic acid cross-linked, Synvis, Durolane, and many more. There's about 5 Supplicin. There's probably about 5 products like that on the market. There's platelet-rich plasma, PLP injections, and they work and they don't work in knee osteoarthritis. Depends on what trials you read. There's many trials where they haven't been more successful than just injecting saline, a fake, or freezing lidocaine. And there's some trials where they have been effective. Platelet-rich plasma does have some success, though, in other areas like tendonitis at your elbow, so tennis elbow. Platelet-rich plasma has positive data, and some ankle area problems as well. So that needs more data to routinely recommend it for osteoarthritis of the knee, say. And then there's also injections that we do not recommend and are not recommended by most orthopedic organizations, which would be stem cells. And stem cells are who knows what. You take something from your plasma from your blood, it's spun down, it's injected back into a joint, and Health Canada says we don't know what the heck it's doing. It's not standardized, and if right now in general it's not ready for prime time. So a lot of treatments, but weight loss, muscle strengthening, orthotics, other aids can also be good treatments. And topical things like hot chili pepper, capsaicin could be helpful too, as well as diclofenac.
Okay, so thank you, Dr. Pope. Now, with all of these different medications on the market to treat both inflammatory and osteoarthritis, could you speak a little bit to some of the most common side effects that people should be aware of?
Right. And this is an excellent question. And I know it came up many times. So thank you, everyone that asked a question similar to this. So, first of all, let's remember that when I'm talking about benefit, I'm talking about on average, this many people had this much of a response. We are not an average person, we are all individuals. So the other thing, so we never know what will work within an individual and who will have side effects at this point in time. AI or other personalized care will help us over time, but we don't know that right now. That's the first principle. The second principle is if something that is regulated by Health Canada, which are the prescription medications that your nurse practitioner, your family physician, your specialist prescribes, if they were way too harmful and not beneficial enough, they'd be off the market. So first of all, any drug has potential benefit and potential side effect or risk. So most drugs have enough benefit to be on the market, or well, all drugs, or they'd be pulled from the market. But so let's talk about some of the common drugs. So if someone has rheumatoid arthritis, our anchor drug is methotrexate. And the most common side effect of methotrexate, believe it or not, is no side effect. But at least 1 in 10 have significant nausea that can last a day to a few days even, or several days after they take it. It's a once-a-week medication. Side effects can be tempered by splitting the dose, giving it by injection under the skin or in the muscle as opposed to pills, lowering the dose, changing the interval instead of weekly, how it's approved. Sometimes I'll go every 10 days to 14 days if someone's doing well with rheumatoid, but not doing well on side effects, or I'll lower the dose. Also sores in the mouth, nausea, and just feeling unwell or fatigued. And then methotrexate, leflunomide, not so much our biologics, but our targeted synthetic drugs, can all potentially give low blood count, so anemia or low blood, low platelets, usually not low enough to be of concern, a low white count. If it's low enough, there could be an increased risk of infection. We follow blood counts then, and therefore down adjust if there's an issue. But many people that have slight abnormalities don't need an adjustment. It's not going to harm your immune system significantly on slight abnormalities. And lots of our drugs can elevate liver enzymes. So on methotrexate, we suggest drinking not at all for alcohol, or in moderation, but not daily. Not a moderation, we consider 2 drinks a week, maybe, except for when people go on holidays. We sometimes say you get a pass then if you're going to an all-inclusive, and maybe hold your methotrexate. But leflunomide, azathioprine, mycophenolate, the targeted synthetic DMARDs, all of those drugs could elevate liver enzymes, but methotrexate can rarely damage a liver. It's not usually sudden, it's decades of use. And we have kids with juvenile arthritis on high doses of methotrexate. Kids clear, relative to their body weight, they clear methotrexate faster than adults. And I'll have a kid with polyarticular juvenile arthritis who in adulthood still needs her methotrexate, and she could be on methotrexate for 60 years. So at times, we sometimes have to, not always, but we have to look sometimes more carefully. Say if someone has diabetes, they're overweight, they have high cholesterol, or they have a fatty liver for other reasons, we have to make sure we're not scarring the liver irreversibly, because if we are with methotrexate, we have to stop. So we monitor by ultrasounds, by fibroscans, by blood tests, by history, physical, and risk stratifying all the time. But there's hardly ever will I have to stop methotrexate because of some of these because of severe liver problems. I do have to stop it sometimes. Up to 1/3 of people over time might come off methotrexate because they're better in remission. Great, they can come off. Or more likely, of that 1/3 of people, sometimes it's because they just can't tolerate it anymore when we've tried all our tricks of the trade. So sometimes methotrexate's a long-term anchor drug. Sometimes it's not tolerated well enough to be used for decades in people.
Okay, that's great. So this next question, I really like asking this at all of these arthritis talks, but it does seem particularly relevant to tonight, as the world of arthritis medications is just changing so quickly. So what excites you about the future of arthritis treatment and medications, Dr. Pope?
Right. So again, what a wonderful question, and what a high note, right? Because so first of all, I'm excited about drugs that I'll talk about that might be coming, but I'm also quite excited about personalized medicine. I think artificial intelligence, and maybe just a finger prick, the way you can do a finger prick and you can do a blood sugar and know what's going on right now with someone's blood sugar. Wouldn't it be great if we could say, I do a finger prick or a little venipuncture, a little blood draw, and can find out that you will tolerate methotrexate. It's highly likely it'll put you into remission, and you have a big chance of being on it long term. We're not there yet. So we do trial and error. And what's even more important, methotrexate is inexpensive, widely available. Every drug plan covers it. And it's our anchor drug in rheumatoid arthritis. So I don't even need to know as much about methotrexate as, okay, what about after methotrexate and leflunomide or hydroxychloroquine, sulfasalazine and methotrexate? What about after those drugs are no longer effective, or maybe in some cases not tolerated and rarely contraindicated? Do I use a TNF? Do I use a targeted synthetic drug? Do I use an IL-6? Do I use a rituximab? Do I use an abatacept? What do I do? Or if it's psoriatic, would an IL-12/23 or an IL-23 or an IL-17 or a TNF, what's the best way to go? Wouldn't that be great? I don't know. So I'm excited that at my career as a practicing rheumatologist, I believe will be better than today. And the analogy I make is, before we had as much AI, and AI is really exploding, before we had that, breast cancer changed dramatically in the last 10 years, where there's more markers. The treatment is based on the markers, it's based on the staging. And that's true in colon cancer. It's based on staging and markers, et cetera, et cetera. So I think we're going to get there. So I'm very excited that I will hopefully be able to use personalized medicine. I think we also have to do research to get these answers. So that's why it's important to support the Arthritis Society, who funds wonderful research. But that's just my plug, but I believe in it, or I wouldn't put the plug in right now. So that excites me. The other things that excite me are some of the rare or less common diseases. So we now have 2 biologicals in systemic lupus erythematosus, and we will have several more, including oral drugs, to come. There are many drugs in lupus in what we call phase 3. That's later stage randomized controlled trials. And I think we're going to have oral drugs and other biologicals to come. And in kidney lupus, we are not batting 100%. We have a lot of recurrence of renal lupus or kidney lupus. And now we have drugs where really all the data say, starting with a whole bunch of medications or front end loading, and then backing off over time might become the new standard of care, instead of just either cyclophosphamide or mycophenolate mofetil with prednisone and with background hydroxychloroquine. The other cool thing is we've always borrowed from cancer drugs, we borrowed from psoriasis drugs, we borrow from other diseases, and we are learning about these other diseases by the things like personalized medicine, doing drug targets, looking at drug levels, looking at anti-drug antibodies. So that's the Crohn's or ulcerative colitis approach in inflammatory bowel disease. And we're learning their strategies in our diseases. Some of them, we taught them strategies. Now the GI gastroenterologists are teaching us strategies. So that gets me excited. And I have lots of excitement, but a final area of excitement is, I think within a few years or less, that we are going to have highly effective drugs for osteoarthritis. But there's a caveat. They're going to be for early osteoarthritis, not the end stage where people have bone-on-bone damage, where we can't regrow cartilage in a patient for bone-on-bone damage. But for early osteoarthritis, we're going to have strategies where we can prevent them from going down that pathway of more pain and suffering, and getting to joint damage, a failure of a joint, and joint replacement. And joint replacements are going to be more effective too. Joint replacements, when I first trained, lasted, some of them 5 to 10 years. Now we have joint replacements, not me, orthopedic surgeons do it, but because of great research and great funding for research, they have joint replacements now that, and some of my patients will last lifelong potentially. So we've come a long way. So I've covered a lot of different areas that I think are really super exciting. So Sean, back to you.
Yeah, I love all of that, and all of that is super exciting. Maybe I'll just, before I get to some questions, do you have any final thoughts, or do you just want me to dig into the questions?
Well, let's dig into the questions, because when 2 minutes are remaining, I'll probably have new insights to tell people.
Wonderful. Okay, so we do have a number of questions, so let me try to share these in some order that makes sense. Okay, so the first question here, we've had lots of questions about side effects of treatments and people who are taking other drugs. So you talked a bit about side effects, but specifically, can you talk about any sort of contraindications or concerns between arthritis medications and blood thinners in particular? I'll list a couple, but tell me if you mean, start with that and I'll go on with others.
Sure. I think that's, again, blood thinners are really common because atrial fibrillation is probably at least 25% of the population lifelong. Not everyone will have it the rest of their life, but 1 in 4 people. And the treatment of atrial fibrillation for most people is some sort of blood thinner. The DOACs, or that's the rivaroxaban, and other ones, there's like about 5 DOACs now, but they're the blood thinners. And then warfarin, the traditional old-fashioned blood thinner. And then blood thinners after you get your heart bypass or your heart attack, or the stent where they do an angioplasty or put a metal drug-eluting stent or a non-drug-eluting stent. They bypass inside and crack open the hardening of the arteries. All those things in there, like Plavix, that's the most common one, but there's others. And some people are on both of these. They're on a blood thinner and of a DOAC and Plavix. So the problem with these blood thinners are, if I'm giving you a non-steroidal anti-inflammatory drug, an NSAID, if you get an ulcer on the NSAID I'm giving you, a stomach ulcer or gastritis, you could bleed. And when you're on 1 or 2 blood thinners, you could really bleed. There also can be drug interactions where sometimes the non-steroidal anti-inflammatory dose is increased, but more likely the NSAID is increasing the blood thinning potential, rarely decreasing it. So we have to be very careful. So if I have a patient, say, on apixaban for atrial fibrillation and they have osteoarthritis, I would really try to avoid an NSAID. And I would say, well, if we have to use one, let's go topical, which is safe. The absorption of a topical is very, very low. If you eat it, that's a bit of a different thing, but nobody eats their topical. So it's safer. And I would then try certainly Tylenol, or that's acetaminophen. I would try joint injections and stuff, so I try to avoid it. And it's the same if someone's had an ulcer, we try to avoid the NSAIDs and we try to protect the stomach as well.
Okay, great. What about people who are on drugs for diabetes?
Right. So I was going to say as an exciting breakthrough too. So we borrowed from diabetic drugs. So the drugs from diabetes that are the flozinate, they're really quite excellent. They can decrease kidney problems. They decrease heart failure, and the flozins and the Ozempic kind of drugs, they're a different class of drugs. They will decrease heart attacks by 50% in people with hardening of the arteries who don't have diabetes. So these drugs are awesome. So usually we don't care about drug interactions because those drugs can help us. But otherwise, some diabetes meds, and more so some cholesterol lowering meds, the statins, can raise liver enzymes. And we sometimes are worried about raising a liver enzyme in a drug like when we use our methotrexate or leflunomide or azathioprine, because that can also raise the liver enzymes. But the cool thing about some of their drugs, this is not on label. I'm just telling you research. This isn't routine care. But if someone's on metformin, if someone's on a statin, that's your cholesterol lowering rosuvastatin, atorvastatin, that's Lipitor, Crestor, those kinds of drugs, they can actually decrease inflammation in rheumatoid arthritis, even though they're not approved in rheumatoid. So they have added bang for buck. They can help your diabetes or your cholesterol, and they can help your rheumatoid arthritis and psoriatic arthritis probably as well, a little bit. They're not our primary drugs, but they actually have a wee bit of added value. So we kind of like those drugs, and we love the flozins. They're the glycosides and things that we just love those drugs because they're good. They're good on organ systems. And we love the Ozempic kind of drug, not just for helping for weight loss. It's because they decrease heart attacks in heart people at risk. So people with hardening of the arteries by 50%. Pretty amazing.
So interesting. And maybe my last category of drugs to think about with arthritis drugs, what about antidepressants?
Right. So antidepressants, there's no bad drug-drug interactions on normal dosing of the drugs that I would prescribe for rheumatology patients, and the antidepressant doses that would be prescribed for depression or for fibromyalgia and chronic pain. So not all of them, but some can have an added benefit in helping pain control. And I must say, for chronic pain, let's hope that we have a magic bullet sometime, or a directed thing that's more effective than what we have now, because at most, for our chronic pain medicines, that's pregabalin or Lyrica, Cymbalta, duloxetine, and some of the other antidepressants in those chronic pain categories. I think they work at most in 1 in 6 to 1 in 3 people with chronic pain. Some of them it works and they're not tolerated. Some of them they don't work enough. And some of them are side effects and just they're kind of like a zero. So not in every patient will they be helpful, but antidepressants do have some positive benefit in pain in some people, even if they're not approved that way. And that would be Effexor, which also interestingly treats hot flashes. And all these drugs, I'm sorry, I sometimes say one name and sometimes I give you two. Every drug has a trade name and its actual generic name. So sometimes I interchange them. I apologize for that. But otherwise, no major drug-drug interactions. The other thing is for antidepressants, they're not for everyone. There's people with depression. When you have chronic pain from your arthritis, when you have chronic pain or chronic depression because Maybe you've lost your job. Maybe you have pain and suffering and can't sleep from the diseases that I am treating every day, like rheumatoid or psoriatic or scleroderma or lupus or so many other ones. If an antidepressant is tried for your depression, you would go and with your family doc or a specialist, a psychiatrist, or whoever's helping to treat you. And if it doesn't work, speak up. Maybe they'll up the dose. Maybe they'll stop and say, this isn't for you. And there's non-drug therapy that can help your depression for some people. Talk therapy, psychotherapy, cognitive behavioral therapy, positive journaling. Believe it or not, exercise is almost as good as an antidepressant for someone with mild depression, not severe depression. That's a whole different category. So don't try to be over medicated, because I will try to over medicate people by accident. I like to use lots of drugs in rheumatoid arthritis to get remission, and then maybe back off, maybe not over time, but not the antidepressants. That's those disease modifying drugs.
Okay. Many people here have asked for alternatives to NSAIDs if for whatever reason they can't take them themselves.
Right. So first of all, for osteoarthritis, in general, NSAIDs are better than acetaminophen, 3,000 milligrams a day, for pain control. But acetaminophen has a wider safety margin. It doesn't cause ulcers, so it's not going to give you low blood or anemia. It's safe in most conditions at the right targeted dose. So in general, acetaminophen, that's Tylenol. Topical NSAIDs are okay. I mean, if someone has a severe aspirin allergy, nasal polyps, and asthma, I'm not going to touch them with even a topical NSAID, because those people can have severe allergic reactions or anaphylaxis with NSAIDs, but they're very rare. They're like in an allergy clinic, they're seen, of course, more than a rheumatology clinic, but very rare, very, very rare. But people can't use NSAIDs if their kidneys don't work. Sometimes on the blood thinners, it's not preferred. Sometimes with inflammatory bowel disease, high blood pressure, heart failure. There's a lot of contraindications, or mild or like relative or absolute contraindications. So Tylenol, topical, then you would ask, could you get referred to someone that sees osteoarthritis, maybe sports medicine, maybe ortho, maybe rheumatology, maybe somebody else, and say, phys med rehab, hey, is there other stuff that can be done? Would injections work? Would other things work? So even, we don't do this usually, but even a nerve block just above the knee can give pain control for patients with osteoarthritis for a period of time. So say someone has to walk their granddaughter down the aisle at a wedding or something like that. Maybe they want to have a bit of pain control for that, a long weekend. So nerve blocks can be helpful. So there's a lot of things that are not off the shelf usually that can be helpful when you can't take an NSAID. So there is hope to offer other things for people that can't use NSAIDs for sure. And for rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis, NSAIDs and ankylosing spondylitis are first-line therapy. But if you're bad enough, the biological drugs are used, or the JAK inhibitor drugs. If you have rheumatoid arthritis, we used to have 85% of our patients on chronic NSAIDs. Now we have about 20% in rheumatoid arthritis. It's really changed over about 20 years because of all the great treatments we have, and also because the old-fashioned treatments we use more effectively. So great question.
Okay. Can you talk for a moment about Tylenol versus Advil versus things like Tylenol for arthritis? Just help people understand when you would make choices to take different medications like that.
So if you don't have the reasons to not take Advil, like your kidneys work well, your blood pressure is good, you don't have heart failure, you don't have low blood or severe anemia, you haven't had an ulcer, all those things, then it's really a patient preference. And I must say, more people prefer, for arthritis pain, not always for headaches, not always for other things, for arthritis pain, it's probably a 2-to-1 preference of the Aleve, Advil, Motrin, ibuprofen kind of drugs over Tylenol. But in fairness, most people are not going to take 3,000 milligrams of Tylenol a day. So with that being said and done, it's whichever you work. So when patients say, it's the same as when they say, should I put heat on my joints or cold? And I go, whatever works, hot, cold, whatever you like. But more people prefer heat to cold, but not everyone. It's like that. More people prefer the Advil to the Tylenol. But There's Tylenol Arthritis, which is a longer acting. So Tylenol comes in 325 milligrams, 500 milligrams, 650. Tylenol PM has probably something, a little bit of something to help you sleep, which is probably more like Gravol or Benadryl in it. There's Tylenol Arthritis, which is slower released, so you don't have to use it like every 4 hours. You can use it, say, 3 or 4 times a day. So I think you sort of get what works for you. It's worth more money if you don't have to take it as often and it gives you good relief. But it's not worth it if you say, I just need 2 Tylenol plain before I go do the groceries. Then that's all you need. You don't need 3,000 milligrams a day or fancy. They're not that fancy, but more expensive ways that it's broken down in your body. If you wake up at 2 to 4 a.m. every night because of arthritis pain, I would think of a long-acting Tylenol instead of 2 slow-acting, like 2 fast-acting 325s. So that's where I'd say think of Tylenol PM or Tylenol Arthritis, which might give you a longer half-life so you're not waking up in pain. Because that's a drag to have a pill and a glass of water at your bedside because you wake up from pain. We don't want that. We can usually help people with that.
Okay, great. A few people here have asked, how can you tell, or how do you know if you have inflammatory arthritis or osteoarthritis? And can you have them both at the same time?
Right. So you don't always know, as a person living and experiencing arthritis, you might or might not see swelling with degenerative or what we call osteoarthritis. You the distribution, you can have a lot of swelling and warmth and pain in your fingers, the middle knuckles and the end knuckles with erosive osteoarthritis, very common in women. About, I always say it can start at any age, but often around 10 years before to 10 years after menopause. Often mom or grandma had it, so it runs in the family, but more in women. Even though it's autosomal dominant, women manifest it more, and they could have very warm and aggressively damaging joints. And we say, well, that's osteoarthritis. But it's erosive, it's breaking down things really quickly. It's quite painful. And that's why sometimes, but not usually, but sometimes even methotrexate is used for people that, I'll call them hot tamales, really warm, swollen, tender joints, and they can't function. But mostly we use the anti-inflammatories, Tylenol, joint injections, topical, and we hope for disease-modifying drugs to come. So that's the one, and that's one extreme. But if your hip has pain, mostly it's degenerative arthritis, not always, but mostly. And by the way, your hip is your groin, but it can hurt in your thigh or your knee. So your hip can hurt in your knee, but your bum is your back. So your bum is not your hip. That's the back there. That's from usually degenerative arthritis. So everyone listening will have, I'm sorry to say, including us, will have degenerative arthritis. So degenerative disc disease is almost universal once you're over about the age of 40. And so we all have degenerative disc, and that's most common in your neck and your low back. And that is treated with sometimes injections of cortisone, sometimes the anti-inflammatories, physiotherapy, etc. So inflammatory arthritis is often, I won't call it more severe, the pain, but it's more significant, the heat and the swelling. So you might see a great big swollen wrist or swollen on these knuckles that attach your fingers to your hand. So MCPs, maybe a big swollen ankle, but not from fluid retention. It would be warmth and swelling, especially if it's one ankle. That's usually not fluid retention. That's usually in both ankles. Big, swollen, warm knees. So sometimes it's not easy to tell. And we haven't talked much about crystal arthritis, gout and pseudogout. So crystal arthritis can really be quite inflamed, really hot, maybe warm, very swollen joints, especially for gout, especially ankle, foot, midfoot, great toe, knee sometimes, and wrist sometimes. But if you're on a water pill, Lasix, furosemide for heart failure for many years, I say the older lady with heart failure, they can get gout that mimics rheumatoid, but it affects these end knuckles as well. But that's quite swollen and painful. And that kind of gout isn't usually red, whereas acute gout, like in the textbooks, or someone that drinks a lot of alcohol or eats shellfish or heavy amount of red meat, and they get that, it's quite sudden sore red swollen joint. So how do we tell? We tell by the history and the physical. If I don't know what you have by the end of your history and physical, I might need x-rays or supporting labs, or I might need it for grading how severe is something, is there damage or not. But we usually know by history and physical. But don't expect that your family doc would know that. Your family doc knows lots of great things, how to treat your diabetes, your cholesterol, your blood pressure. They're excellent at that. They don't see new rheumatoid very often. Rheumatoid's 1 in 100 people, so they have them in their practice. But the incidence of rheumatoid isn't 1 in 100. That's incidence over the next year. There will only be, maybe 1 in a couple thousand people is the incidence, but the prevalence is 1 in 100. So same psoriatic arthritis, ankylosing spondylitis, lupus, things like that. So usually the family doc will refer you along to a specialist if they're not sure what's going on or if they feel they need help. And if they suspect inflammatory arthritis, or if you suspect it, take pictures of swollen joints to show your family doc and then say, do I need a rheumatologist? Because the answer is either yes, no, or I don't know, but keep asking if they're not sure.
Okay, great. You talked a bit ago about biologics and biosimilars. Could you just briefly explain what biosimilars are? And questions here about should people be taking biologics before they try methotrexate? What's the treatment strategy there?
Right. So your easy treatment strategy is it's tiered because of benefit, because of cost, so cost effectiveness, and also because most biologics head-to-head of methotrexate and rheumatoid arthritis, most biologics aren't superior. They're superior after you fail methotrexate, absolutely. So methotrexate is our first-line treatment in psoriatic arthritis and in rheumatoid arthritis, not in ankylosing spondylitis. Doesn't work and the spine doesn't penetrate right. So that's why biologics are used later. If biologics were pennies on the dollar instead of dollars, maybe we would change the strategy a little bit, but we can get biologic access to most people in Canada quickly if they need it after failure of what we'll call other routine care. And it's because of the cost. A biologic is a big molecule usually made from a living organism. So believe it or not, hamster ovaries were some of them, but mostly it's E. coli making it. So they're making copies of a great big molecule. So a biologic, we know what we're inhibiting, but the batch to batch is not identical. So a biosimilar is a drug approved in Canada by Health Canada that has proven to be acting the same as the originator molecule. And that's where I had the stars like adalimumab, the originator was Humira. Now there's 8 other adalimumabs. So they're biosimilars because they were after their what we used to call subsequent entry biologics. And a biosimilar is not identical to the originator, but it's almost identical. But the originator is not identical to the originator. There's batch to batch variation. So the biosimilars are as similar to the originator molecule in the batch to batch, because they have to be, as the actual originator molecule. So when we say they're not identical, they're biosimilar, the actual originator is also biosimilar to itself. It's not identical batch to batch, but the important binding sites, the active ingredient, the molecular weight, all the major structural parts that have to be to link on and bind are all identical. It's sometimes a weirdo side chain that's irrelevant. I say it's weirdo because it's not going to hurt you. It's just an irrelevant little part of the molecule. Structurally can be a little bit different. And so you can have good confidence that a biosimilar approved by Health Canada should do the same job as the originator. The problem is sometimes you break through, like I'm an optimist. We'll end on an optimistic note shortly, but all good things come to an end. So sometimes our immune system can tell if someone, you can break through. Your immune system says, I can get around that. It's like a loophole in a contract. So sometimes your immune system gets around a biologic or a methotrexate kind of drug or whatever. And so then you have drug resistance. So that can happen to about 10% of people on a biologic every year, 25% year 1, 15 to 20% year 2, and 10% annually thereafter. So if I put you from your innovator or originator drug, say Humira or Enbrel or Remicade, onto the biosimilar, 10% of people per year might no longer get benefit because that would have happened on the originator. So, but it really is sad when you're doing great and we switch you, and then 4 months later, the drug's not working because you go, that drug didn't work. It's that biosimilar. But it's because 10% of our patients every year will lose benefit, unfortunately, on their great biologic. Could have been great for 6 years and then you lose benefit. So
Mhm.
just keep that in mind when you have, most of Canadians have switched, but not necessarily on private plans. But we switch because of saving money. There's no other benefit than they're not better, they're biosimilar. They're really good drugs, all of them. And we're switching to try to save the system money.
Yeah. Okay, that's wonderful. So you talked about some of your patients being on, for example, methotrexate for decades. So a few questions here about, is it safe to be on these drugs long-term? So for example, Celebrex, is that safe as a long-term treatment option?
Right. So the easy answer is maybe. So I'm hedging a little bit, and I'll tell you why. There's two things that can happen. We all get older. So if we're older, we have a higher chance of stomach ulcers. But as we're older, we might, because if you're on it for a long time, we might get new hypertension, high blood pressure, kidney problems, bit of heart failure, maybe a bit of anemia, low blood for a reason. Then the safety goes down. So that's the first thing, is if your risk changes over time, we either get rid of the drug, we down adjust the dose, or we give a stomach protector, depending on what your risk is. But the other thing is, yeah, it's safe to be on a lot of these drugs long term if you don't have strong risk factors for bad outcomes, on like for side effects. But a lot of our drugs, our NSAIDs, also stop working over time in about 1/3 of people. So I could have someone on naproxen, say naproxen, for 6 years, and they go, I'm having more pain. And I go, but your rheumatoid's really good. It sounds like you're having more osteoarthritis pain. How are you taking your naproxen? Oh, I'm taking it faithfully, although you can take it as needed too, by the way. You don't ever have to take NSAIDs at the full dose for osteoarthritis. You can just take them as needed. But then I'll say, well, why don't you stop it? Because you'll know in 2 days. If you're on it every day regularly, you'll know in 2 days, 3 days, that if you stop it and you're way worse, it's like, oh my goodness, it is helping. Or I stopped it and it was doing nothing. Eventually, our immune system, drug tolerance, for whatever reason, our system will say, you know what, this drug is no longer getting into the cell, or it's coming out of the cell quickly, so it's not doing its job anymore. So then you could be exposed to risk without benefit. So yes, you can use some of these drugs long-term, but sometimes they stop working. So if you feel it's not working, stop it and see, with consulting your doctor or your pharmacist or your healthcare professional. And also, if someone's had a heart attack and now they're on the 2 blood thinners after a stent, after they got the angioplasty in their heart and the stent, then we would say the first thing cardiologists will do, stop that Celebrex, stop that whatever you're on, the NSAID, because they slightly increase heart attacks, or they don't. Even in Ontario data, they sometimes do, sometimes don't, depending on how you cut the data. So they might have a slightly increased risk of heart attacks, not much.
Okay, great. I think we only have about a minute left. I'm going to try to squeeze in two what I think are interesting questions at the very end. The first is, are there any drugs that you're available that are targeted to preventing arthritis? And kind of related to that, do you see a future for a cure someday, some way down the road?
A future for what?
For a cure.
A cure. Oh my goodness. Well, I mean, Arthritis Society talks about the cure. I'll answer the cure first. So the cure is tough because there is not one arthritis. There's like about 100 kinds, and I've talked about 8 or 10 kinds, just maybe 12 kinds on this 1 hour. But basically, will we get cures for some of them? Maybe. In my lifetime, probably not. But will we do better? Yes, we are doing better. Our patients are dying less of their diseases. They have more, some cancers, especially blood cancers, but some cancers are more, some cancers are less, but they also have more heart attacks and cardiovascular events, so heart attacks, strokes, than the general population. But they have less damage now. So there's a lot of hope. But a cure is a different kind of question. On the other, but we do put people into long-term remission. We didn't when I trained. We did, but not very many. Now we do more for lots of these diseases, not all, but some of them. On the other side, but I'm not giving up. We're going to find more things, and maybe we'll have a cure of one of the kinds of posteoarticular JIA or something. Who knows? Prevention. So we think of prevention of general population, at-risk people, people with symptoms, and people with the actual label or diagnosis. So there's a few things. If you eat a good, because I know there were some diet questions we didn't get to. If you eat a good, healthy diet, and a healthy diet for me might be different from a colleague. So a healthy diet is often Mediterranean, not a lot of meat, not a lot of red meat, more fish, more free omega-3 fatty acids that come from the deep water fish. Lots of protein from vegetables, chickpeas, hummus, stuff like that. Lots of any colored fruit or vegetable. Lots of different colors is a healthy diet as well. In general, for most people, if you eat a healthy diet and you take vitamin D, just 1,000 units a day, you might decrease your chance of getting autoimmune diseases by a smidgen. But why not? Healthy diet, vitamin D. There's possibly data on omega-3s preventing arthritis, but not as good as vitamin D. Vitamin D had better data, but the two together were even better than either one alone. So omega-3, but again, omega-3 is always best obtained from your diet if possible, if not by supplements. That's fish oil. So omega-3, 6, 9, or omega fish oil, and at the dose that it's prescribed. And the final thing here, because I'm cognizant of like the clock ticking, would be if you have arthritis, in the early stages, we can turn off some of that spreading of the autoimmune system, the epitope spreading of your rheumatoid factor, your anti-CCP, and put you into deep sustained remission, which is kind of like a cure, not always drug-free remission, by treating effectively early with the right treatments. And these are our common drugs, not fancy, expensive drugs. So I think there's a lot of hope on that whole spectrum of prevention of arthritis.
Thank you so much, Janet. You are such a wonderful wealth of knowledge on all things. That was amazing. We'd just like to take a few moments to get the audience's feedback on today's presentation. So for those of you who are watching on Zoom, you'll see a poll question come up on your screen with some options. So do click on the response that reflects your thoughts. I feel more knowledgeable and empowered after attending this webinar. Now, we will also be sending you an evaluation form when we email the recording and the slides. So if you weren't able to access that poll question, you'll have the opportunity to give us feedback at that time. And we really do use the survey feedback to shape future Arthritis Talks webinars, and we value your input very, very much. Once again, we are grateful to Nordic Pharma, Pfizer, and United Way Winnipeg for their financial support of this event. And as a wrap up, I want to thank all of you, your participants, for your participation and your interest. And our discussion really does show how far we have come because the efforts of researchers who are tirelessly working to create life-changing treatments. But there's much more we can achieve together. So this month, Arthritis Society Canada is running a Make It Monthly campaign, giving you an opportunity to make a lasting impact all year long by joining us as a monthly donor. Your consistent support empowers us to expedite innovations and advancements in research, and every donation really does count. So to join us as a monthly donor, please visit arthritis.ca/makeitmonthly. We will be back on April 11th for an Arthritis Talks focused on pain management. More information and the link to register will be included in an email to you tomorrow. So this does conclude tonight's Arthritis Talks. On behalf of all of us, thank you for joining us today, and please stay well.